Welcome to the webinar, everybody. This is Why We Do What We Do, the Brain and Addiction Treatment. I'm Creek Walker. I'm a board-certified neuropsychologist and forensic psychologist. I'm looking forward to spending some time with you this afternoon on what's my favorite topic, the human brain. This talk is sponsored by the Foundation's Recovery Network, and I want to remind you that you can submit questions on the bottom left of your screen at any point while I'm talking. All of the questions will be answered during the last 10 minutes of the program. You can also find a PDF of this presentation and additional resources under the headshot image located on the left of your screen. And if you need any assistance, please email Melissa Pangaro at mpangaro@naccme.com. Need to tell you about how to get credit for this. In order to receive credit, you must watch the program all the way through to the question and answer section at the end of the presentation. Do not leave your console. Please continue to stay on the platform and you will be automatically redirected to an evaluation landing page. If this is your first time attending a webinar in 2019, you will need to create an NACCME account when you are first directed to the landing page. For all subsequent webinars you attend, you will already have an account and you'll just need to log in. After completion of the evaluation, you will be able to download or print your certificate. NAADAC credit is only offered for the live broadcast. Okay, the human brain, the single most complicated and complex thing that we know of in the entire universe. It consists of about 100 billion neurons. Estimates range from somewhere between 90 and 130 billion, and about as many glial cells to support those neurons. The typical brain has about 100 trillion connections, so it's by far the most complex thing that we know of in the universe. And of course, the brain is why we do everything that we do as human beings. Every thought, emotion, feeling, behavior that we have is a direct consequence of events that occur within our brains. The brain controls absolutely everything that we do and is ultimately the source of everything that we do, think, and feel. It's the source of human personality. It's the source of our value system. It's, of course, can ultimately attributed, all human art can be attributed to the brain, all of human history, all of our knowledge, everything that we have to do with regard to relationships and communication with other people, our culture, our sexuality, our politics, and of course, overarching all that is human consciousness. Human consciousness is a construct that's created by the human brain that we don't really have any understanding of why it happens or how it works. But we do know that, of course, that our brains produce consciousness because you and I are consciously listening to this presentation today. We have the ability not just to see, hear, taste, feel, and touch things, but also to know that we're hearing, seeing them, tasting them, and touching them. In other words, we have a meta ability to step outside of ourselves as human beings and reflect on who and what we are and what we're doing. And this is a vital thing that separates us apart from other animals. I'm going to come back to that in a bit in our talk. The brain is also why we do what we do as treatment professionals. We essentially are brain healers, whether we're in the field of psychiatry, psychology, psychotherapy, behavioral therapy. All of us who work in the mental health field are involved in trying to correct disorders and heal illnesses that have to do with the human brain. And all the mental disorders in our diagnostic and statistical manual can ultimately be attributed to actions, disease, and disorders within the brain itself. And finally, the brain is why we do what we do as addicts. And that's going to be the point of the presentation today, is trying to understand addiction from the point of view of human brain functioning. Addiction is an affliction that affects somewhere around 1 out of 10 or 1 out of 12 people in our nation, results in incredibly expensive losses in terms of financial losses, not to speak of the human losses that go along with it. Recent estimates put the yearly cost of addiction in the United States as close to $1 trillion a year. So it's a tremendously expensive and difficult situation. Let me talk a little bit about myself before we go on with the presentation, just to give you a little bit of an idea about where I come from and how I'm approaching this talk today. I got my start in the mental health field as a mental health patient. When I was a teenager, I came down with obsessive compulsive disorder and major depression at the age of 12 or 13, and suffered from those illnesses throughout the course of my teenage years. The condition was something that I couldn't go see a mental health provider for because my parents didn't believe in mental health treatment. And so I essentially suffered with those conditions while I was a teenager, but I read absolutely everything I could get my hands on about the brain and mental illness and the mental disorders that I recognized as a teenager that I had. And I developed the desire as a teenager to become a psychologist someday, somebody who was an expert on human behavior and could, in fact, help other people get better. When I was 18 years of age, I went off to college, and the first thing I did when I set foot on the campus of college was make an appointment with the college psychologist. And so I went to see him for psychotherapy and instantly experienced a tremendous benefit and change in my life because of that treatment. And that solidified my desire to become ultimately a psychotherapist or psychologist someday. And so I went to the University of Louisville, their Ph.D. clinical psychology program, and studied primarily psychotherapy and psychological assessment during the course of my 5 years there. The University of Louisville had a very active research program in psychotherapy, trying to understand not just how to do psychotherapy, but what makes good psychotherapy and what differentiates it from bad psychotherapy, what kind of treatment actually helps people to get better. And so that became my focus, and I had my career oriented in that direction. I then went on to do my residency at Vanderbilt University. I chose Vanderbilt because they had a very active psychotherapy research program there with Hans Strupp, the great psychotherapy researcher. And so I chose Vanderbilt, only to find out when I got there that the psychotherapy residency slot had already been filled, and I was going to have to find another way to use my time there. So instead, I went into neuropsychology, and in my residency at Vanderbilt University Medical School, studied neuropsychology and became an epilepsy researcher. I evaluated people before and after their epilepsy surgery and got to actually see what kind of changes happen when you remove different portions of people's brain in order to try to control their seizures. That led to an absolute fascination on my part with the brain and how it works and how our tests can best identify issues and problems in the brain. From Vanderbilt, I went on to become a traumatic brain injury specialist at a TBI rehabilitation hospital where I was for 2 years. And then I got a job as a forensic psychologist at Texas's maximum security forensic hospital, where I worked with the very worst of the worst in terms of the criminally insane. And that was an illuminating experience as well. I went on from Texas back to Vanderbilt, where I served for 12 years as the director of forensic services in Vanderbilt University Medical School's forensic services program. I then went into private practice as the owner and operator of a professional evaluation center where I did fitness for duty evaluations on professionals suspected of impairment of some kind or another, and collected a team of professionals around me who were skilled at doing those kinds of evaluations. We had a psychiatrist, psychologist, neuropsychologist, alcohol and drug counselor, and several other disciplines who would participate in multi-day comprehensive evaluations of professionals. And during the course of my career, I've also served as an addictions consultant to several treatment facilities around the country. Finally, I also have the qualification of giving this talk in that I'm also an addict myself. Addiction is a disorder that has affected my life tremendously. I got a very late start in addiction. I didn't become an addict until I was 35, but it has had a tremendously negative impact upon my life, personally, professionally. Absolutely everything that has happened in my life has been affected by addiction in a negative way. And it's only, thankfully, through a course of recovery that I can be here giving this talk to you today. But something interesting happened to me while I was trying to get clean all those years. And one of them was I went to several addictions treatment facilities myself as a patient. And I had the same experience everywhere that I went. The first day I was there, they told me, there are these things that you need to do in order to deal with your addiction. These were things like you need to go to meetings, you need to get a sponsor, you need to take your medication, you need to change these things and not these other things. Now, being the good, I'm not sure what I'd call it, I guess maybe being the good addict that I was, or being the good difficult person that I was, my response to that was, well, where's that coming from? You don't know me. You can't tell me what I need. I mean, you don't even know who I am. This is my first day here, and you're telling me that all these things that I have to do in order to get better. That doesn't make a lot of sense to me. What's happened over the course of the last several years of my life is I've come to understand how those things don't just make a lot of sense, but they also make a lot of sense from a brain perspective. I'm going to talk later on in the talk about how recovery principles and recovery recommendations and suggestions make a lot of sense from a brain treatment perspective. And of course, thank goodness things are a lot better for me now. So the question came up in my mind, why don't we teach addicts about their disease from a brain perspective? In other words, if there's this collected wisdom in all the treatment personnel and treatment centers around the country about how to deal with addiction, why don't we actually take the opportunity to teach individuals that we're treating about their illness from a brain perspective? We've all seen pictures like this showing the disease that happens in a person's brain as a result of various kinds of addiction. Up at the top here, we see a healthy brain, a PET scan of an individual compared to a person who's cocaine addicted. We can see tremendous hypometabolism across the course of that person's brain, has chronic cocaine addiction. We see in the second tier there a normal compared to an individual who's intoxicated with alcohol. And these are the same kind of pictures that we see in any kind of a disease process in the body. We see down below the PET scan of a healthy heart, and we see the PET scan of a diseased heart. Just like we can see disease in a person's heart, so we can also see the disease in their brain. So it makes sense from my point of view to begin teaching addicts about how their brain is functioning, or maybe a better way to put it, about how their brain is dysfunctional. I think this makes a lot of sense because, for one thing, it shows our patients respect. It shows them that we do have we have their best interest at heart, and we're treating them as grown-ups. We're trying to teach them the things that we know and why we're saying the things that we're saying. It affirms their autonomy as human beings. It enlists their cooperation and participation in their treatment rather than just simply telling them what to do or writing a prescription for them. It reinforces the disease concept in their minds in order by going about and reaffirming the idea that they're suffering from an illness rather than it being an issue purely of personal responsibility, which also, by the way, addresses the issue of shame. It's not something to be ashamed of. It's simply a disease. And it short circuits, in my experience, the patient's resistance to treatment. In other words, when you deal with an individual from an educational or didactic level, it dramatically changes their stance towards it. Everybody who comes in to receive psychotherapy or some kind of treatment these days, it seems, wants to know, what's my diagnosis, what's my disorder, and what's the issue with it. And so I think teaching an individual educationally about their disorder both fills a need on their part, and it gets around the natural resistance that we all have to change. Another good thing about this approach is that it teaches or it allows a model or a system that all the treatment personnel can agree upon and follow. We have lots of different individuals in treatment centers, many of whom have different philosophies of treatment and different ways of addressing addictive disorders. But one thing is certainly true, and that is we can all agree that addiction resides in the human brain and that the changes that have to happen are ultimately things that have to happen in the brain as well. And then finally, I think this kind of educational approach illuminates for the addict the sole and only path to recovery. The only way for an addict to get better is to grow, to redevelop their mind and brain to the point where the use of the substance no longer becomes necessary for them. So this is how I go about working with addicted patients. I use the treatment metaphor of your brain app. I tell them, imagine that you have a brain app on your telephone that tells you when and what to do about everything all the time. You're constantly checking your app for instructions. When anything happens, you always check your brain app to tell you what to do, how to feel, and what to say. And then I explain that, in fact, this is very close to reality. We each go through life acting the way we do, thinking of the things we think, feeling the way we feel, because of our brain. Absolutely everything we do, think, feel, or say is because of our brains. Somebody says something unkind to us, we feel sad. That's because our brain made us feel sad. We have something positive happen in our life. We feel pleasure. That's because our brain has registered pleasure. Someone cuts us off on the interstate, and we feel angry and upset about that. We had that reaction because of the programming within our brain. So this is very close to the way the brain really works. The brain is constantly almost commanding us in a way of how to think, feel, and act on a moment-to-moment basis. And so my instruction to the patient is simply to imagine that there is an app that exists on their phone, is telling them every moment what to do, and they have to consult that all the time. I then tell them, now imagine that someone has hacked into your brain app. They've messed up the settings. Instead of telling you healthy things to do, your app tells you that your response to most things should be to use drugs or drink. Having a bad day? Use drugs. Having a good day? Drink to celebrate. Time to go to the gym? Drink a little weed, or smoke a little weed instead. Feeling stressed, sad, happy, angry, lonely, tired? Use more drugs. The app always gives the same instructions about the same things. This is addiction. The patient's brain has been hijacked by addiction. The patient's only hope is to recognize that his or her app is broken and that he has to get his app reprogrammed. But this takes time, treatment, and refusing to follow the app's commands to use. Now I'd like to switch course here for a moment and talk about a brain model of addiction. And note that I say a vastly simplified model of addiction here. There are many, many portions of the brain that are implicated in the disease of addiction. And we could probably talk about 15 or 20 different different brain sections very easily. I'm going to primarily focus, though, just on 4 interrelationships among 4 brain areas to make this very accessible. The first one is, of course, the nucleus accumbens, the amygdala, the ventral tegmental area, and the ventromedial prefrontal cortex. And all of this, the information I'm going to share with you in a moment, is going to be informed by what we've learned about neurogenetics in the brain. All right, let's talk about these different brain regions for a moment. Let's first of all talk about the nucleus accumbens. The nucleus accumbens is the pleasure center of the brain. It's where we register everything that happens from a positive point of view. If we have a good feeling, it's because our nucleus accumbens has registered that feeling and is evidencing pleasure over it. It receives and projects dopaminergic neurons to and from the ventral tegmental area. It receives and projects glutamatergic neurons to and from the prefrontal cortex. It's intimately interconnected with the entire limbic system, all of the portion of the brain that is involved in feeling and motivation. The nucleus accumbens is highly interconnected with that portion of the brain. It is especially interconnected with the amygdala and hippocampus, portions of the brain that are highly involved with emotional reactions and learning, and we're going to talk about that more in a moment. fMRI scans of individuals who are being given their drug of choice, addicted individuals who are being given their drug of choice, shows that the nucleus accumbens becomes wildly excited at this point. This shows us that it's the portion of the brain that is really registering that tremendous pleasure. It's implicated in all addictive behaviors, all human addictive behaviors, drugs, alcohol, and even behavioral addictions like gambling and sexual addiction. If we look at addicts who are involved in whatever their addiction is, when they're practicing their addiction at that moment, we can take a scan of their nucleus accumbens and we can see tremendous activation there on the fMRI scanner. Let me also mention that the nucleus accumbens is neurogenetically programmed for some chemicals, but not for others. I don't know how many meetings I've attended where an alcoholic described the first time that they consumed alcohol. And many times that story goes something like this. You know, we were at my friend's house, I was 16, and we got into his dad's liquor cabinet, and I drank a shot of Jack Daniels. And all of a sudden, I knew that everything was right with the world. I became the life of the party. Everything felt great. I was excited. I felt at peace. I felt wonderful. And I knew that that was an experience that I was going to have again and again. Many times I've spoken to patients who told me about their first prescription of Lortab or hydrocodone from the dentist, how they went home and took that pill after the dental work. And they said, oh, it felt so wonderful. All of a sudden I had the energy necessary to get through my day and to clean the house and do all the things that I needed to do. I felt like everything was right with the world. I knew it was something I was going to seek out again and again. Each addict, the nucleus accumbens, is programmed sometimes for different drugs of abuse or even different activities of abuse. And it depends on our neurogenetics as to exactly what kind of addiction we're going to be susceptible to. None of us knows walking down the street what manhole we're going to fall into, but we can be sure that many of us have manhole covers left off that are awaiting us. If we try that particular substance or chemical, we're going to have that addictive reaction. The nucleus accumbens is profoundly associated with the survival ability of the organism. Now, this makes sense. Think about it. It makes sense that we as organisms, living organisms, would want to feel pleasure when positive things happen that are useful from a survival point of view. We eat a really good meal. We experience a really exciting bout of sexual activity. We have a really good time with friends. Anytime those things happen, our nucleus accumbens registers the pleasure associated with them, and it's just simply normal and natural for us to feel positive. And it's a way for our brain to keep us active in doing the things that we need to do to stay alive and to continue to propagate our species. Unfortunately, with the addicted person, the nucleus accumbens is profoundly associated with disease and death. So our nucleus accumbens have been so hijacked by the addiction that instead of having survival value, now our nucleus accumbens has been reprogrammed to make us want to seek out activities that are tremendously deleterious to our health. Moving on to the second area of the brain I want to talk about is the ventral tegmental area. The VTA is a part of the brain that is involved in learning, operant and classical conditioning. And the kind of learning that the VTA is centered on is the kind of learning based upon prediction error. What this basically means is our VTA registers events in our lives that have unexpected pleasure or unexpected aversive consequences to them. So we have something occur that we weren't expecting that brings tremendous pleasure. The VTA says, aha, I'm going to look at everything that is associated with this pleasurable event and try to remember it for the future because this is something we want to experience again and again. For example, I can remember when I was a child going to visit my grandparents' house in southern Ohio. I remember one summer I was visiting my grandfather and he said, Creek, it's time to go blackberry picking. I said, well, Grandpa, how do you know it's time to go pick blackberries? He said, well, because it's July the 4th. In southern Ohio, that's when the blackberries come in. And sure enough, we went out in the fields, and there were loads and loads of bushes filled with these gigantic blackberries. I also noticed that everywhere that there were blackberry bushes, there was this pretty white flower, very tall and straight, that I later learned was named Queen Anne's lace. Wherever I saw a Queen Anne's lace flower, I would see a blackberry bush. Queen Anne's lace, blackberries. Queen Anne's lace, blackberries. And that unexpected reward at the end was my grandmother's blackberry cobbler that she made at the end of the day. What an unexpected positive reward. What happened in my brain during that time, even today, if I go hiking in the fields, the instant I see a Queen Anne's lace flower, I immediately go on the hunt for a blackberry bush because I know that they're nearby. In fact, I recently traveled to New Zealand to visit a friend of mine there, and the same association holds in New Zealand as well. They also have Queen Anne's lace flowers, they also have blackberry bushes, and they grow in exactly the same place. I learned from a little research, by the way, that Queen Anne's lace and blackberries actually have a relationship evolutionarily, whereby the bugs that are attracted to Queen Anne's lace also serve a function in pollinating and keeping pests away from blackberries as well. So that was something I had not known before. But in any event, you can see how the ventral tegmental area works. It associates characteristics of reward-producing behaviors or events with the pleasure involved. It's dopamine mediated. It has tremendous survival value to the organism. You can imagine, you know, although, of course, as a young boy, I was not at all dependent upon those blackberries for survival, you can imagine how that in time past, Aboriginal humans walking through the fields, and they come upon this bush loaded with beautiful blackberries. It's going to be important for them to do everything that they can to remember the location and the characteristics of that event so that in the future they can recreate that event and have more blackberries to eat for the rest of their lives. So it has tremendous survival value. And the VTA is the portion of the brain that registers that unpredicted reward, that unpredicted error. It's involved in any kind of cued recall that the brain is involved with. It's involved, of course, in wanting behavior. And for the addict, unfortunately, it is also involved in the craving behavior of addicts. Here are a couple more slides just to talk more about the interconnections of the ventral tegmental area. You can see that the VTA is intimately interconnected here with all the different portions of the human limbic system, as well as the frontal cortex. Here's another similar slide showing the interconnections between the VTA and the nucleus accumbens to the medial forebrain bundle and then the prefrontal cortex as well. So you can see how these different brain areas are definitely very interconnected with one another. Okay, the amygdala, it's a Latin word for almond, and if you've seen it on brain dissection, you know it is about the size and shape of an almond. There are two amygdala in each human brain. They're located deep within the temporal lobes. They're adjacent to the midbrain, which is where the VTA is located, as well as the hippocampus and forebrain, where the other areas we've been talking about are located. Here is a DTI image of the amygdala and its connections. You can see how the fibers project intimately with other portions of the limbic system as well as the frontal cortex here. So the amygdala is highly involved in the learned fear response. If you have a particular issue in your life that you have a phobia about, your amygdala is involved in, unfortunately. In the amygdala, the brain has found a way to simply bypass any kind of conscious reflection, and it can result in an automatic reaction by a direct circuit between the thalamus and the motor strip, bypassing the prefrontal cortex. In other words, essentially your brain's decision-making apparatus is suspended with the automatic response that's mediated by the amygdala. If you have some extremely terrifying and upsetting event, your brain recognizes this is something that under all circumstances you must avoid in the future, and any kind of indication of that life-threatening or traumatic event, your brain goes into an automatic reaction, and it becomes almost a closed circuit where there is no conscious control involved. Your brain simply sees something that it's terrified of, and it automatically acts to protect the person against that traumatic event. It's involved in any kind of emotional overreaction that we might have. The amygdala is very intimately associated with human aggression, and also emotional blunting. When a person has bad things happen to them over and over and over again, over time the amygdala shows an emotional blunting response where, associated with the person not having strong feelings any longer in relation to bad things happening, they then experience this emotional blunting that's mediated by the amygdala. Moving on to the ventromedial prefrontal cortex. This is the dashboard of the brain, if you will. Let's talk a little bit about how this part of the brain works. We have here a classic setup, and many experiments have taken a look at this in terms of rat self-administration of cocaine. What they do is they hook up a rat to a device that will automatically deliver small quantities of cocaine directly into their brain. And whenever the rat presses a lever, they get the cocaine. What happens when a rat is set up with this kind of apparatus is the rat will ignore food, will repeatedly self-administer cocaine, ignoring food, water, or opposite sex rats. And it will continue to self-administer that cocaine until it dies. Now, obviously this doesn't happen with humans, even if they become addicted to cocaine, although certainly some people die of cocaine addiction. It's not something that always results in that outcome. And I think that's an important thing for us to look at as treatment professionals, is what sets apart the human brain from the rat brain. Here's a picture of the rat brain. Here's a picture of the human brain. As you can see, the two different brains are tremendously different in terms of their smoothness. The human brain is tightly folded, has many, many more interconnections. The rat brain is much smoother, reflecting much less complexity. The cortex in the rat brain is much smaller in proportion to the rest of the brain. The frontal lobes are much smaller in the rat brain. Here's through the middle view of a rat brain. As you can see here, this almost looks like a human brain that has a ridiculously shrunken neocortex. This is the midbrain we're seeing here, which is gigantic in comparison with the rest of the brain. And the rat's cortex is relatively very thin and very poorly developed. So what sets apart human brains and rat brains is the difference in the neocortex. Here's a quote that I love from the Narcotic Anonymous basic text, talking about the effect of addiction upon humans. It says, higher mental and emotional functions, such as conscience and the ability to love, were sharply affected by our use of drugs. Living skills were reduced to the animal level. Our spirit was broken. The capacity to feel human was lost. And we know that the rat, hooked up to that cocaine device, is in a hopeless state. As long as the drug is available, the rat is dying, and he will soon be dead. Humans, however, have something that animals don't. We have a highly developed frontal cortex that's capable of executive functioning. We're capable of perspective, of prediction, of forethought. In moments of clarity, we can see the bitter end ahead. In this, and perhaps in this alone, lies the possibility of salvation. The thing that makes humans well human is that we have a very large neocortex. We have a very large frontal cortex. Neuropsychological testing shows that this is where human executive functioning resides. And the ventromedial prefrontal cortex is particularly critical for decision making. These are the executive functions that are mediated by the human cortex. We know now that it's not just the frontal cortex that's involved in executive functions, but really the entire cortex working in conjunction is necessary for really high-level executive functioning. But these are some of the activities that are involved in executive skills of the brain. These are essentially skills or activities of the brain that allow us as humans to step outside of ourselves, step outside of what our brain is doing at any given moment, and reflecting upon what's happening, taking a stance from a higher point of view, saying, okay, if I keep doing this, what's going to happen? What's the right thing to do in this circumstance? What's the smart thing to do? How do I deal with all these different kinds of complex information coming in? How do I go about changing my behavior to adapt to the environment? These are the executive functions that are mediated by the frontal cortex. And evidence suggests that the ventromedial prefrontal cortex is dysfunctional in addicted individuals. We look at this by giving people a test, neuropsychological test called the Iowa Gambling Task. In this test, participants choose cards from 4 decks. 2 of the decks produce high initial reward, but they also have very high penalties eventually. The other 2 decks show slow, steady rewards. And what we know is the individuals with ventromedial prefrontal cortex lesions show a preference for the 2 bad decks. In other words, if you have a brain lesion in this portion of your brain, you over and over again choose the wrong deck instead of the right one in terms of the outcome. And this suggests that individuals with ventromedial prefrontal cortex lesions have difficulty in temporally discounting rewards in favor of longer-term benefits. When we look at direct studies of addicts and their behavior, we see exactly the same thing as individuals with ventromedial prefrontal cortex lesions. Polysubstance addicted individuals, as well as cocaine-dependent subjects, amphetamine abusers, alcohol-dependent, they all show the same propensity towards choosing the decks that have high initial payoffs but worse overall rewards. And if we look at fMRI studies, we can see that the VMPFC is involved in making such decisions. In fact, it's the exact area of the brain that lights up under those circumstances. So let's quickly look back over our vastly simplified functional model of addiction here. We have the 4 different portions of the brain. Here's a model of the normal pleasure-seeking behavior of the human. Here we see pleasure resulting in reward-seeking behavior. That's perfectly normal. We have rationality and judgment that is contributing to this. We make a decision about what time and place is most appropriate to seek those rewards. And we have that entire process being driven by wanting. Our ventral tegmental area is telling us, do the things that feel good, do the things that are positive, and this produces a normal reward-seeking behavior on the part of the human. Here we have instead the model of the addicted brain. Here we have what I'm going to call pleasure salience, represented by the nucleus accumbens. And notice that the pleasure salience is modified by 2 things. One is pain and trauma sensitization by the amygdala. So here we have a person who perhaps has experienced tremendous trauma to where it's much more difficult for them to feel positive emotions. And so for that person, perhaps pleasure salience becomes much more important in their nucleus accumbens than a person who has not experienced that pleasure. So when this individual is exposed to a drug that activates their nucleus accumbens, it makes them feel much better than they normally feel. It makes them feel, in fact, normal again, like we talked about those people expressing how they felt when they took their first drink or their first drug. And also notice the pleasure salience is modified by genetic affinity. This is what we talked about earlier, again, when our brains are essentially hardwired for some substances and not for others. So here we have an individual who has a pleasure salience that has been affected by trauma and genetic affinity. This results in cravings. Once they experience that very positive reaction to the drug of choice, their ventral tegmental area then says, this is something we want to experience again and again and again. And any kind of reminder of that experience is something that we want to seek out. And that results in atypical or abnormal or unhealthy reward-seeking behavior, namely drug use. And notice in this model that rationality and judgment of the prefrontal cortex is not connected to anything. This is a person who has stopped thinking about their drug use. This is a person whose rationality and judgment and values and prediction and all the different things that their brain would normally be telling them, it no longer is an input to this. This has become a continuous loop of where a person's brain has essentially become hijacked by drugs. Addicts are literally not in their right minds. The behavior is not the result of immorality or stupidity. It is illness. And unfortunately, the only way to fix the brain is to fix it. It requires sober time. It requires motivation. Many times it requires skilled treatment, and it always requires, in my experience, a community of support. This is what I tell my patients addiction is like. It's a man going fishing in a wading pool. His world has become very, very small because he's gone back to the same well again and again to get the same return, and it's not working for him any longer. That corresponds to or conflicts with what a fishing trip in real life is like, where you go out in the ocean and you catch some really big fish. You know, addiction is like a tiny sandbox where you're playing like a little child with tiny little toy trucks and things of that nature, when life, in fact, is much larger and much bigger. So let's talk a little bit now about treatment and recovery concepts and how they make sense from a brain perspective. And I'm going to talk about how I utilize these concepts in working with addicts. The goal here is to utilize our neuroscientific understanding of addiction to counter the anosognosia or unawareness of the illness, defensiveness, and lack of awareness of the patient to facilitate treatment. And hopefully, maybe we'll educate and counter the resistance of some treatment professionals as well along the way. So let's first of all talk about the anosognosia and denial. It's often said that addiction is the only disease that tells you you don't have an illness. This, of course, is false. Lots of mental disorders involve unawareness that you have a disease. Schizophrenia is probably the worst offender there. So do many physical illnesses. How many times do physicians tell individuals, for example, who have diabetes, they need to take their medications, need to watch their diet, and how many of them actually do that, or instead are in denial about their illness? So assessing a patient's level of insight is important, and addressing their level of insight, in my experience, is critical in addiction treatment. How do you assess insight? Well, we can all go back to graduate school or medical school here and talk about the different levels of insight. A person with absent insight has no awareness that there's a problem. They have no distress whatsoever. This is a person typically who might have a personality disorder or a person in the early phase of addiction where there really isn't a problem. They're not aware that there's a problem. Other people around them might recognize that there's a very big problem, but for the person himself or herself, she has no awareness that there is a problem at all. This moves on up to minimal, where you can become distressed. Partial, you know there's a problem, but it's everybody else's fault. It's not my fault. It's everybody else's fault that I feel this way. You have good insight, where you're aware that there's a problem, and the patient's accepting responsibility for the problem. And then excellent insight, of course, is the patient is aware that the problem is related to a mental illness, and the patient is motivated to comply with treatment. So addressing lack of insight in addiction is crucial. This is where the rubber meets the road, in my experience, in addiction treatment. Skill here sets aside the effective clinician from the ineffective or harmful one. Remember that addiction treatment is psychotherapy. We know what works. I talked to you earlier about being involved in psychotherapy research studies. One thing that every psychotherapy research study I'm aware of has said about psychotherapy effectiveness is that it's the relationship between the patient and the therapist that is healing. The strength of the relationship is what drives the healing process for the individual. And so as addiction therapists, as psychotherapists in the field of addiction, we need to be very careful and pay a lot of attention to our relationship with our patients. And lots at stake here. This is war. Strategy is vital. Lives are at stake. Immense patience and unconditional positive regard for our patients is absolutely required for this process to work. We have to really genuinely care about our patient and become emotionally connected to him or her and be incredibly patient with where they are in their treatment process in order to have any hope of effectiveness. And this means that the typical things that we think of many times as psychologists or psychotherapists or psychiatrists in terms of interpreting to patients what's going on with them, confronting them, or prescribing a treatment, we only consider doing those things very carefully and in the context of the quality of the therapeutic relationship. Our patients many times are not in a position to accept our recommendations or our insights. We have to wait for them to become receptive to our insights before we share them with them. This requires empathy. It requires many times motivational interviewing, where instead of doing a traditional top-down, this is your problem, this is what you need to do about it kind of interaction with the patient, you deal with the patient from a motivational interviewing perspective, asking questions like, if you ever do think you might want to change, what do you think would have to happen? Open-ended questions, questions that acknowledge and verify their autonomy as human beings. Sometimes it's appropriate in addiction treatment to appropriately self-disclose as a professional. Other times it's not. Again, this is a choice that has to be judged based upon the patient and where the patient is at the particular time. This can really go wrong at times if you inappropriately or too prematurely disclose issues about yourself to your patient. This can be used as weapons against you and in furtherance of their disease in the future. Hearing stories is really important to get around insight. This is one of the fabulous things about meetings, recovery meetings, is that addicts get to hear stories that they can identify with and recognize that they're not the only person who has been where they are, but other people have gone through exactly the same thing that they have done. Paradoxical intention is a very clever and useful tool in psychotherapy, where you essentially side with the patient's resistance, but also what you're doing is at the same time siding with the patient. A classic example here is telling the alcoholic in denial that maybe he should go out and try some controlled drinking and see how that goes. What you do when you say things like that as a therapist is you're essentially putting yourself in the same camp as the patient's resistance, and that gives the patient an opportunity to let down his defenses enough to let you in and see that you're actually willing to consider things from his perspective. And one of the things we know about compulsive patients or any kind of compulsive behavior is that for whatever reason, paradoxical intentions work dramatically in improving that behavior. Another lesson learned from psychotherapy research. And then finally, what we're talking about here, of course, is education about the illness. This is how we go about getting past a lot of the resistance with patients, is talking to them about their illness from a brain perspective. So let's talk here. Now, this is Dr. Creek's education program, Your Addicted Brain and How to Fix It. The goal here is to address lack of insight and resistance via provision of information. In this program, we avoid unsupported pronouncements. We don't tell people that they're addicted. We don't say get a sponsor. We don't go to meetings. We don't say take your medicine. We consider, first of all, why should the patient do what we suggest? We must gain her trust. We must appeal to his curiosity and his intellect. We must provide her hope. We must appeal to his self-interest. Again, we're being the smart therapist here. We're trying to find a way to get on the patient's side. Here's one of the things that we encounter in addiction treatment. One of the first things that people are told is don't drink and go to meetings. Another way to talk about this from the point of view of my model here is to ignore your app. Your brain is telling you, your brain app is telling you over and over again to use during the day. Don't do what your app is telling you to do. This is the cornerstone of addiction recovery. It's also a paradox because by definition, an addict or alcoholic is someone who can't stop. And this recommendation here relies on the fact that we all have at least two minds. We have the addicted brain that's been hijacked by addiction, and we have our frontal lobes that are not working properly, that are capable of perspective, but we're not using them. So we have to use our unique capacities as human here, our executive functioning skills, those frontal lobe skills, to step outside of ourselves, to look at our behavior and to go against what our app is telling us to do. Take your medicine. Sometimes it's very difficult to get patients to take the medicines prescribed. Of course, there are lots of objections. There's a 12-step prejudice against medications in many parts of the country still. People raise the objection that it's not right to use mind-altering substances to combat mind-altering substances. And, of course, there's abuse potential in many medications that are prescribed. But there's a good neuroscientific basis for this. Psychopharmacology is a vital tool in treatment, especially if a patient has a dual diagnosis issue like bipolar or schizophrenia. It's critical that their underlying psychiatric problem be addressed. And, of course, buprenorphine saves lives. Bupropion reduces cravings in stimulant-addicted subjects. Antabuse and Vivitrol have a place in treatment, in my opinion. So these are important things from a brain perspective. Stay in treatment. Tell your patient it's a chronic disease that requires persistent treatment. We'd never suggest that a diabetic no longer needs to watch their diet or take their medications. Time alone will restore the receptor dysregulation that's taken place in the brain. Residential treatment, of course, provides some insulation from relapse, and it takes time for our frontal lobes to come back online. And here's a particular thing I want to say. Relapse is not a reason to terminate a person's treatment. It's a reason to intensify their treatment. And I think we have another presentation coming up here about how many treatment centers and sober homes have gotten into a lot of difficulty from kicking patients out on the street when really it's something that they need to simply intensify the treatment they're getting. Recognize your powerlessness over your illness. How does this make sense from a brain perspective? There are a lot of objections to this, of course. The patient says, well, I can stop anytime I want to. The moral view of addiction says there's a lack of willpower. And as mental health professionals, we think we need to increase the self-efficacy of our patients rather than telling them they don't have any power over it. But, you know, when you think about it, it does make sense from a neuroscientific perspective. We don't choose our genes. None of us chose what addictive substance makes our nucleus accumbens light up. We don't choose our early childhood experiences. We can't change the fact. We didn't want to be traumatized as children. We can't readily alter our brain functioning. In addiction, our use becomes automatic and unthinking. And so at the very least, addicts have a very limited power over their addictive behavior. And remember, again, what we learned from paradoxical intention therapy. Surrender here is power. The person who gives up, sometimes the person who wins. Change the people, places, and things. I'm going to just briefly remind you of the VTA and the Craving Center, how important it is to combat triggers and get patients to catalog their triggers and recognize that triggers are a very important part of treatment, and many times those things need to be changed. Find an ultimate reality. This is maybe a bit of a controversial topic. Many scientists would say, well, I'm a scientist, I'm a psychiatrist, I'm a psychologist. I don't have anything to say about religion. And certainly this is an immensely private issue, and bringing in religion raises all kinds of concerns. But from a neuroscientific point of view, and in my personal experience in addiction treatment, for the addict, it's true that the addiction has become their ultimate reality. Their addiction has become their ultimate reality, their higher power, if you will. And in order to combat the addiction, the person has to find something more compelling than the addiction. And for many addicts, this works. It happens early in recovery. They have what's called the pink cloud, where they're very enthusiastic about the spiritual aspects of the program, and they're enjoying early sobriety. But I think it also makes sense when we think about metaphysical thinking, that it stimulates and exercises the frontal lobes, and that's distinct, in my view, from providing people with the content of belief. Many 12-step people are atheists or agnostic, but the point is they've thought about what an ultimate reality should be for them, and whatever it is, they've found it and they work towards that. Here's a quote that I'm running out of time a bit. I'm going to leave this quote with you. It essentially talks about the importance for individuals to find that ultimate authority, that ultimate reality for themselves. Brief aside here on fMRI scan. I'm going to let you take a moment to look at this and answer, what substance do you think this person's brain is on at the present time? Here we see, centrally there you see the nucleus accumbens is lit up. Up at the top, we have the anterior cingulate gyrus that is activated. We have bilateral temporal activation. Certainly looks like this is a person's brain who is experiencing some kind of intoxicating event. Actually, this happens to be a Mormon believer who is thinking about God. And so you can see how things happen to the brain when people begin to think in terms of ultimate realities or things higher and bigger than themselves. This is something to consider. Get a sponsor. Why does this make sense? Well, for the addict, the decision-making characteristics of the brain are hopelessly at a loss. Help in decision-making is vital. The person's prefrontal cortex is no longer working. Find somebody to help you through early recovery and help you make decisions about your life. The benefit of one addict helping another is unparalleled. And finally, we tell individuals in treatment to work the steps. We say things like the same person will use again, or all you need to change is everything. And of course, this is a tall order. Even incremental change in therapy is difficult. In addiction, we're basically telling a person you have to become a different person in order to cope with your addiction. Unfortunately, although none of us like that reality, there's excellent neuroscientific basis for this. Our brain model of addiction implies that a total reordering of the human mind is necessary. The limbic involvement of the brain suggests that dramatic emotional change is required. The prefrontal cortex show that we have to have a huge refocusing on values, decision-making, and how we approach gratification. And certainly, addressing issues of historical trauma is critical as well. So, I think that these are good recommendations and can be well supported from a brain behavior point of view. Now, I've included here what I call Dr. Creek's 12 steps for the 21st century. You know, the 12 steps are suggested in the big book as a program of recovery, but there's nothing magical about exactly the 12 steps. I hope I'm not horrifying some people, but I have taken the liberty here of reinterpreting them a bit in a way that maybe more addicts and alcoholics can accept. The first one is step one, admit you're powerless. In other words, accept oneself for the fallible, broken, in need of help that one is. Step two, recognize that there's hope, something larger than oneself. In step three, we surrender. We become willing to change our way of thinking and behavior. The original step three, of course, said we turned our will and our life over to God. I remember being at a meeting once, and this fantastic speaker says, I was so troubled in early recovery about how I could give my will and my life to God. I didn't even know there was a God. How is it that I could do such a thing? And then she said, I realized one day that in order to give over my will and my life, I simply have to change the way that I think and I act. And I think that this gets at that, changing our thinking and our acting. Step 4, embark on a journey of self-understanding and awareness. Step 5, you can't do it alone. Take somebody with you. Step 6, love yourself enough to get ready for big changes. Step 7, let go of the things about yourself that are holding you back, the character defects. Step 8, fearlessly review where past relationships have gone wrong. We're social animals. How we relate to other people is critical in diagnosing our character. Step 9, accept responsibility for our mistakes and try to correct them. Step 10, live a conscious, examined life. Go back to the frontal lobes there. We're trying to remain aware of who we are and what we're doing and what our responsibility is. Step 11, we stay connected with what's important spiritually, emotionally, physically. And step 12, we act with love toward other addicts and hopefully towards everyone. We're reprogramming our apps here. The person who does these things, who thus reprograms his or her brain, will not, cannot live in active addiction. That concludes my presentation, and now we're going to move on to the question and answer time. I'll try to get to what questions that I can. Let's see what is here. Let's see, the first question I have on my screen here is, are patients and families really ready to incorporate education about the brain in the recovery process? The answer to that, in my experience, is a dramatic yes. People are not only ready, they're hungry for this kind of understanding. To talk about how the brain works in addictive illness, in my experience, gives an opportunity, an in, if you will, to where both the addicted individual and the family is much more receptive and much more open to what you're having to say. It allows them to objectify or externalize the illness to some degree and recognize that there's, to some degree, they don't have full responsibility over what has happened to their lives. And it provides a framework for explaining to loved ones why their addicted loved one is doing the things that they're doing that are so upsetting and seem so out of character for the person they've known and loved their entire lives. It's a very powerful mechanism in my experience. Step 2, is there really value in traditional 12-step recovery from a psychiatric brain perspective? I think so, and I think maybe I tried to direct this talk into acknowledging what is positive and what is useful about 12-step recovery. 12 steps is essentially a way to reprogram your brain. It's a way to live life differently and hopefully over time to literally become a different person, a person that no longer needs to use in order to cope with life's vicissitudes. 12-step, I think, has a lot to offer. Research about its effectiveness shows that we certainly haven't come out with anything that's more effective for many people. And I think it has a lot of value in our treatment. Certainly it's not everything, but it's certainly not a tool to be left aside either. Question number 3 is, what do I do with recalcitrant, entrenched in denial patient from this perspective? Boy, I can identify with the frustration that it sounds like this person wrote this question, their perspective. We all know the patient who is so absolutely in denial or so absolutely impervious for any kind of input that it's just so frustrating sometimes to work with people like that. And I would suggest that you consider some of the recommendations I've already made. I mean, it's very important to, number one, recognize where that patient is in his or her life, his or her thinking, and recognize that, to some degree, they need to be respected and valued for where they are. That may mean doing things like paradoxical intention suggestions. Maybe you're right. Maybe it's not time for you to deal with your addiction. Maybe it's time to go out and try some more controlled drinking or controlled using. Maybe you're really not that bad. I mean, you come back and let me know how it works. And in my experience, what many times happens when that kind of suggestion is given, it doesn't encourage the person to go out and drink or drug, but what it does is encourages them to be open and give you an opportunity, an in, to register with them and to recognize that, hey, here's a person who's not dealing with me from an ideological perspective or telling me what I have to do or don't have to do. He's really concerned. He's really listening to what I have to say. The next question I have is, what kind of patients are not appropriate for this approach? That's a tough question. I guess there are some people, you have to have some degree of psychological sophistication to think about your behavior in terms of brain functioning. And so maybe, people who are very developmentally delayed or something of that nature, they might have a tougher time with this kind of approach. But in my experience, most patients are open to the idea of looking at their brain as an app, and trying to address how their disease has affected their life and their behavior up to that point. In my experience, this works with lots of folks, and I would encourage you to give it a try yourself. Those are all the questions I'm going to be able to get to in my time frame. I'm sorry for those I haven't been able to get to. It's been a real pleasure talking to you all this afternoon. Please don't hesitate to send me an email or give me a call. I'd be happy to talk about this. This is what I do. This is what I love to do. And I look forward to talking to you soon.